First of all, I am really thankful Turk Miyan साहब and his colleague और आप सब दोस्तों का भी शुक्रिया कि आपने मुझे मौका दिया. Today I am going to discuss critical issues in treating acid peptic disease. I have started with few data. For example, first data is 50 years old businessman having burning sensation in the epigastrium and sometimes retrosternal burning as well. After almost every meal, there is no change in his bowel habit. He is taking antacid and famotidine with some relief. His endoscopy was done that shows multiple erosions in the lower part of esophagus. Biopsy did not show any H.pylori, and his diagnosis was made gastroesophageal reflux disease. And this is the common presentation. Every second patient presenting in GI OPD. Basically, gastroesophageal reflux disease की जब बात करते हैं, it has two variety, endoscopic negative, around 60%, and endoscopic positive, around 40%. Among these who are endoscopic positive, patient may have complication like Barrett esophagus, like stricture, and sometimes without any complication, but patient may present like atypical presentation like chronic cough, and patient may be treated as asthma or atypical chest pain. If you see what's the prevalence of acid-related disorders, across the globe around 14%. But if we see Pakistani perspective, we have around 24%. 71% of our patients, they have spicy food as a major reason. And then nowadays, among our young generation, red drink sting. If you see what are the risk factors for these are commonly NSAIDs, steroids, excessive alcohol, smoking. Then there are certain like blood group O positive people, obese, and patient with hyperparathyroidism, and infection, of course, like Helicobacter pylori. Another case, again 50 years old female having pain in the epigastrium for last 3 months, burning in character, non-radiating, but this pain usually aggravated by meal and relieved by empty stomach. Patient is a smoker and take alcohol socially. Again, he was prescribed omeprazole. Patient took occasionally and now presented with one episode of upper GI bleed, hematemesis. So what do you think this patient may be suffering from? Bleed कहाँ से हो गया? Any of you? Pain after taking meal, usually stomach in origin. Endoscopy was done. You can see there is a large ulcer in pre-pyloric region. अभी इसको और ज़्यादा इस डाटा से आपको ये थोड़ा सा क्लियर हो जाएगा. Another male who is taking, female taking NSAIDs, steroids, and modifying agents for rheumatoid arthritis for last 10 years, presented with pain epigastrium off and on for last 4 months. Non-radiating, aggravated when patient hungry. पहले पे मैंने क्या कहा? Pain aggravated when patient take meal, कि जब वो खाना खाता है तो उसकी पेन बढ़ जाती है. यहाँ पे उसकी पेन क्या हो गई है? कम हो गई है. Pain relief with medication and food. Again, this presented with upper GI bleed. अब इस पेशेंट में देखें और पिछले पेशेंट पे अल्सर था in the pre-pyloric region, in the stomach. Now again patient is having an ulcerated lesion in the second part of duodenum. So remember, whenever patient presented with pain epigastrium, pain aggravated by meal, relieved by vomiting, think about gastric ulcer. When pain relieved with food, और पेशेंट हैव टू गेट अप एट मिडनाइट की रात, लेकिन आजकल तो सारे सोते ही 2 बजे हैं. सो मिडनाइट पे उसे उठना पड़ता है, खाना खाना पड़ता है, तो समझ जाएं कि दिस पेशेंट मे बी सफरिंग फ्रॉम ड्यूडिनल अल्सर. सो अल्सर क्या बेसिकली आप सबको पता है, ब्रेक इन द मिकोजा, रिलैप्सिंग कंडीशन है. मेजर रीजन फॉर दिस इज द हेलिकोबैक्टर पाइलोराई, NSAIDs, steroids, smoking, and bad eating habits. Though there is weak relationship with eating habits, but once patient develop the lesion or ulcer, then symptoms are definitely aggravated by like carbonated drink, like red drink. H.pylori क्या करता है? It is urease producing organism. अमोनिया रिलीज करता है और प्रोटीएज जो है वो अल्सरेशन करता है. सो दोनों मिलके गैस्ट्रिक अल्सर फॉर्म और ड्यूडिनल अल्सर. पाकिस्तान में अराउंड 80 to 85% ऑफ आवर पॉपुलेशन जो है उसमें H.pylori मौजूद है. Risk of developing gastric carcinoma and intestinal metaplasia is around 16%. H.pylori can lead to 10% gastric or duodenal ulcer. And जब इतनी हाई प्रेवलेंस है और उसकी वजह से इतनी कॉम्प्लिकेशन है, if you treat this, you can reduce the risk of cancer or gastric cancer by 32%. So, endoscopy is the gold standard and testing for H.pylori. आप एक चीज़ याद रहे, for the first time you can do blood screening, for example, antibodies, IgA for acute infection, IgG for chronic. But once you treat, कि आपने ट्रीटमेंट दे दी है, you have treated your patient, next time you need either endoscopic biopsy, CLO test, CLO, CLO test, वो आप at the spot testing कर सकते हैं, और stool for H.pylori antigen और यूरिया ब्रेथ टेस्ट. सो ये आप टेस्ट कर सकते हैं, बट वंस यू हैव ट्रीटेड द पेशेंट, अब दोबारा आप स्क्रीनिंग वाले टेस्ट पे एंटीबॉडीज नहीं करेंगे, बिकॉज दैट विल बी ऑलरेडी प्रेजेंट इन योर ब्लड. सो हाउ टू ट्रीट? सो ये जो हमारा अल्सर है, दैट लीड टू कॉम्प्लिकेशन and sometimes deadly complication like bleed. You have to be very smart or soft and gentle, जैसे कि ये चूजा है. Ask your patient, please quit smoking as cigarette lacks lower esophageal sphincter. It promotes reflux, both duodenogastric as well as gastroesophageal, and it also lacks lower esophageal sphincter and decrease the immunity. If patient is having reflux symptoms, then elevate bed by 4 to 8 inches will help the patient. Mostly patients who are obese, they suffer more of gastroesophageal reflux disease. So ask them to cut down their weight. Because obesity not only lead to diabetes में भी gastroparesis हो जाएगी, hypertension, and dyslipidemias. So tell your patient if he is obese, wear loose clothes. Daily physical activity. But remember, if patient is having active peptic ulcer disease, then light exercise, not strenuous exercise, जो कि हम routine में कहते हैं. Avoid spicy meal. No alcohol. Stop carbonated drink, especially red drink, because I have seen the patient कि उसके साथ mucosal ulceration and ultimately candidiasis similar to AIDS patient. इस तरह का बुरा अंदर से मिकोजा का हाल होता है with this red drink जो कि हमारे बच्चे और and it is habit forming कि वो एक बोतल पीता तो फिर आहिस्ता आहिस्ता तादाद बढ़ती जाती है. Stay away from coffee and tea if you have active peptic ulcer disease. And stop NSAIDs. Intergastric pH जो है, it should be more than 4 for 16 hours to relieve reflux symptoms or healing of gastric ulcer. So हमारे पास nowadays we have new drug Vonoprazan जो कि potassium competitive acid blockers हैं. It inhibits acid excretion and it has wonderful result. Advantage क्या है versus PPI कि you can see कि with the benefit appearing as early as first day of therapy. With PPI अगर आप देखें तो day 1 more or less complete action के लिए more or less 4 to 5 days चाहिए. But with PCAP, your action will be within 24 hours. Similarly, when you compare with lansoprazole, in erosive esophagitis, you can see results are more than 92% versus 84%. As far as Helicobacter pylori, that is a treatment challenge because you have to give triple or quadruple therapy with maximum side effect like distaste. So we may need quadruple therapy in which you give PPI, you give PCAP, you give clarithromycin, amoxicillin in high dose and bismuth. अब इसके साथ भी कई दफ़ा पेशेंट अगले दिन आ जाएगा, डॉक्टर साहब काला पखाना आ रहा है, आपने कहा था काला पखाना आए तो मुझे रिपोर्ट करना है. तो याद रहे कि इफ़ यू हैव स्टार्टेड क्वाड्रिपल थेरेपी तो बिस्मिथ का जो कलर है दैट विल लीड टू ब्लैक स्टूल. देन इन दोज पेशेंट you can see results are more than 91% with Vonoprazan as compared to PPI, that is 86%. Important यहाँ पे जो बात है कि whether you are giving PPI or PCAP, please counsel your patient that once he or she has started the treatment, complete 2-week treatment. Though there are regimens that are 7 to 10 days, but results are not as superior as 2 weeks of therapy. How long to treat? Nobody knows. But remember, those like old age hai, patient is having severe osteoarthritis, patient is having rheumatoid arthritis, they need NSAIDs. Among these patients, you may need continuous therapy. Thank you very much.